So this lecture is going to be the final one on the um, step 4 application component of evidence-based practice, and it's going to transition into step 5. So step 4 is deciding and applying what we're going to be doing, and then step 5 then is collecting the data to review the overall process. And so disablement models provide a good transition between these two components because it formulates a foundation for us to consider our decisions in, and then leads directly into deciding what information we need to collect in order to decide whether or not the overall evidence-based process was effective and our treatment was effective. So as far as objectives and key points, basically the objectives for this is going to be to explain these disablement models, but more importantly to show how these disablement models provide a framework for a whole person healthcare, as well as a framework to enhance patient-centered care. So this is going to be where we take the evidence that we have found and apply it with things like the patient values in order to get our overall decision for what we're going to apply, and then finally apply it in a patient-centered way. So to start off with, what is disablement? Disablement basically refers to the effect of the health condition. So moving beyond a simple interpretation of a condition as its effect on the body itself, but now in moving beyond that in order to describe the effect of the condition on the patient as a human being. And so as far as different perspectives on disability, really these are foundational type perspectives to help us build towards the more modern day perspectives. The medical perspective of disability very much is the result of any patient disability is a result of specifically the role that the injury is putting on the patient. So, for example, if there is some disability from a condition, the medical perspective focuses on curing the condition, thereby eliminating the disability. Whereas the social perspective now focuses on the environment as the creator of the disability. So the idea here is that regardless of medical conditions, in the right environment, a patient would be able to overcome the disability. So the focus then is on changing the environment. The biopsychosocial perspective now combines these two to realize that it very much is a combination of both the limiting factors of the condition as well as the environmental factors that create the disability. And so it creates 4 distinct levels. The origin, which is basically the diagnosis or the medical perspective. Then the organ level, and this is where you start to describe some of the limitations in the ability of the body part to perform the activities that it normally does. So these could be things like decreases in range of motion, decreases in strength, but still at the organ level and more medical in nature. Then you transition to the social components more as far as the person and societal, and these now take, because of their inability to have full control over their body as far as organ level limitations, they are unable to perform normal activities in which they would do. This can be anything from running, jumping, cutting, to washing your hair or anything like that. But then that leads to a decrease or a disability regarding the societal roles that that individual were to normally play. So, for example, if you have a soccer player that's unable to run, they're unable to play soccer and participate in the social environment that is their soccer team. And so Nagi was the first one that starts to describe this. And moving beyond the different levels, describe the origin level as the pathology. Right? Basically, what is the condition that they have? The organ level was then the impairments. Basically, what can they not do because of their pathology? And then it gets into functional limitations and disabilities, which have to do with their ability to perform. So when you think of an active pathology in the Nagi model, you're thinking about the disruption of the normal cellular processes. All right, so this is the condition itself. It could be a rupture of a ligament. It could be swelling. It could be inflammation. Whatever the actual pathology is that is going on from a cellular level is categorized as the active pathology. The impairment then is what can they not do because of the abnormality of that tissue, right? And so this is our typical normal clinician-based assessment that we start to provide care for, this idea that we'll have range of motion deficits, strength deficits, neuromuscular control deficits. These are all sorts of things that are very important to the clinician in order to treat the pathology, but fail to incorporate the patient into the care plan. When you get into that, we then get into this idea of functional limitations and then disabilities as classified in the Nagi disability or disablement model. Functional limitations are their inability to perform meaningful tasks that they would normally be able to perform prior to the condition. So similarly to the person level things, these are running, jumping, washing your hair, anything like that. And then finally, the disability model comes into play with this idea of because of these inabilities or functional limitations, they're unable to maintain some of their normal roles within their community. And their community can be any group that they self-identify with. And so when you think of this as a overall goal, this is the first model that really started to incorporate the fact that it is important for the clinician to start to address these functional limitations and disabilities opposed to simply trying to treat the condition. And so you may hear talk within the evidence-based medicine community with regards to the fact that the patient is much more than their injured body part. You know, we don't treat knees, we treat patients. And so the idea here, as far as application in step 4, is once we've gotten our information regarding what interventions might be applied, we bring the patient back into the equation again and start to discuss what sort of things would help them, not only as in order to help their condition, but in order to help them return to their normal functional levels and their normal roles within their social groups. And so you can see an example here using an ankle sprain, where the origin level is the pathology. It's the tear of the ATF ligament as assessed by the anterior drawer. The organ level, as far as impairment, decreased dorsiflexion, and they're assessing that with the weight-bearing lunge test. Then the person level, you can see now we have the inability to run the length of the field, and now we're starting to incorporate more patient-centered measures, things that judge overall patient function. So like sport, the functional ankle assessment for sport, or a time t test. These are things that judge the overall function of the individual opposed to simply measuring ankle conditions. And then the societal role would be the inability to participate in the game. And these get to like whole wellness sort of measures. So the World Health Organization, ICF, or International Classification of Functioning, Disability, and Health, we've spoken about this numerous times within the athletic training program, but want to review it here just from the point of view that because we are now making decisions, we need to consider all of these different components for decisions regarding the application of our interventions. And so you remember that it starts with the health condition or disease or disorder at the top, and that affects the body functions, activities, and participation levels. But at that same point, we have environmental factors and societal factors as well that are contributing within these situations. And so the health condition is that physiological function. Again, going back to the origin level, you can see these consistencies, how they've built one upon the other. The body structure and function is the organ level. The activity then is the execution of the task at the personal level. And then participation is the societal level. But the ICF then starts to bring in this idea that there are environmental and social factors, other domains that are going to be contributing to these situations. And so the environmental and social factors that you see can be anything from past experiences with injury to support systems. And so the environmental situations usually constitute more of the support systems, whereas the societal has to do with their own personal history associated with both injury as well as care. And all of those then combine to create the situation where we're going to recommend interventions. And so you can see, again, same thing here as we go through, but you see now the other domains as far as the athletic trainer, their lifestyle, previous medical history now come into play. So when we get into this situation and we're talking about how we can go about making application decisions within athletic training and going ahead and applying these, once we have the best evidence, we've appraised it, and we've decided that it's relevant to our patient, we're then going to apply it looking for the ways that we can address the entire patient opposed to just their condition. And so once we've applied these treatments, the next thing will be to see if we actually are making the benefit that we hope to. And these benefits are going to move beyond simply the range of motion and tissue level healing things to be more global in nature in these patient-based outcomes and patient-oriented evidence. So that way we can get to a situation where we're improving overall healthcare and not just individual treatment cases.